All right. I'm really happy to introduce Timothy McBride. Tim McBride is the Bernard Becker Professor in the Brown School and co-director of the Center for Health Economics and Policy in the Institute for Public Health at Washington University in St. Louis. Dr. McBride studies health policy and health economics, focusing on health insurance, health reform, rural health care, Medicare and Medicaid policy, health economics, and access to healthcare. Dr. McBride serves as a member of national, state, and local committees and boards, including the St. Louis City Board of Health and the Midwest Council for Cost Effectiveness Public Advisory Council, which I'm also a member of. He served as chair of the state of Missouri's Missouri Health Net Oversight Committee from 2012 to 2019. This is a committee that advises the state's Medicaid program. He's been very active testifying before Congress and consulting with policy constituents on health reform, health insurance issues, and rural health policy. He has served on the Rural Policy Research Institute's health panel since 2003, which provides expert advice on rural health issues to the US Congress and other policymakers. Dr. McBride, welcome.
Thanks so much, Albert, for that kind, can you hear me okay? Great, thanks for that kind introduction, and I'll see if I can manage the sharing of the screen. You can see that okay, right?
Very good.
Great, excellent, and I've been really enjoying these presentations by Sachin and Megan, and one comment I'll make, hopefully this, you'll enjoy this. I have my headset on, and I'm glad I didn't have my speakers on during this talk about Alexa, because I'm sure our Alexa would have been going off about 4 or 5 times if I had the speaker going on, and actually it just did go off when I said that. Anyway, anyway, sorry about that, Megan. That we have Alexa, we really enjoy it. So anyways, I'm here to talk about telehealth and in rural areas, the challenges and the responses to it. And I put this bucolic picture of rural America. We'll get to that in a minute. First, my disclosures. I have some funding from HHS and HRSA, NIH, and Missouri Foundation for Health. I do some work with the Centene Corporation, which you probably know about, insurance company here in Missouri, St. Louis. As Albert mentioned, I work with the Rural Health Panel for the last almost 30 years, which has funding from Helmsley. So I'm going to first sort of talk about rural areas in general. You probably know some of these issues, but I think sometimes it's important for people to get a framing of what rural people face and rural areas face, because it's part of the what I'll talk about after that. And I was listening to Sachin, and I wasn't going to necessarily do this, but I want to frame this. He did a really nice case study of the south side of Chicago, and I want to sort of start with something I've done before, which is sort of talk about what is rural area. And, sometimes, I've done rural health research for about the better part of 30 years. I think about people, when they think about rural areas, they might have different conceptions of what rural America might look like. And you might know some of these pictures. The one on the left, front left, is from the Depression era, classic picture of rural America, Appalachia. The one in the lower part, some of you might be too young to remember it, but is Beverly Hillbillies. And then the classic picture of sort of beautiful rural America that we see if we drive across countries on the right. But I kind of like to run this experiment with people sometimes when I do talks like this, and have people think about maybe like what are the social determinants of areas, and have you think about your own sort of conceptions of what rural and urban America might look like. And I've pulled some statistics of 3 counties. They're all in Missouri. your neighboring state to most of you, I think. And these are 3 counties. I won't tell you which ones they are quite yet. You can start mentally thinking about them and think about whether they're rural or urban counties. And I've pulled their census data on income, poverty, employment rates, their insurance rates, and whether people in the county have a bachelor's degree or higher, percent foreign born, percent non-white. And you can kind of see, you might want to start drawing some conclusions about them. Obviously, the one on the left looks pretty well off, high income. The ones on the middle and on the right, less well off. So, when I do this in person, if I were standing in front of a class or a group, I might say like which one's rural, which one's urban, or which of the 3 are urban. Sometimes people say you're tricking us, they're all 3 rural, they're all 3 urban, whatever. But without making further suspense, I'll tell you that the 2 in the left here are St. Louis County, where I'm sitting right now, the suburban ring around St. Louis City, which is the one in the middle, and which you may not know, St. Louis City's a county in itself, and it's sort of the urban center of St. Louis. And the way to think about that relative to Chicago, obviously Chicago's 5 times bigger, but we have this weird divide between the city and the county, and they should be together, but the county's the richer parts of St. Louis, and the city's the more struggling parts of St. Louis. So, and then the part on the right is a rural county in what we call the boot heel along the Mississippi Delta, which, as you see, has pretty low incomes, high poverty rate, a lot of people without college degrees, a lot of people without health insurance, and so on. So, my point is that it's not always so easy to characterize rural America. And if you bend down in that area, it's going to look a lot like what I'm going to talk about in the next few minutes. So, a major point that I often make is we often try to say that, urban America on the left, some of these brownstones like you might see in Chicago, might be more like the suburban areas down at the bottom, but maybe some urban areas look more like rural areas. And so some of the challenges we face in rural America may be those faced in central cities. And the area that stands out, in my opinion, after looking at a lot of these data for years, is the suburbs. The suburbs are really a lot better off. And so when we design policies to address these challenges, we need to think about that. So let me sort of dive in and give you a real quick overview of some of the really big challenges rural people face, rural places face. Too few health providers, rural closures. You may have heard about all these high uninsured rates, so-called deaths of despair, mortality, morbidity, COVID-19. So one thing is that rural areas have been losing population at a pretty rapid rate. And this is a chart from the ERS. So non-metro population has remained 0 in recent years, this green line here. And during recessions, these gray bars here, population growth drops pretty rapidly in both metro and non-metro areas, but more rapidly in non-metro areas. There are steep declines in the Great Recession, and probably we'll see big declines during COVID as well. We know some of the early numbers on that. But one of the things to note here is there was actually an actual negative growth rate in non-metro areas from in the early 2010s, where you didn't see that in metro areas. So there was depopulation, literally depopulation. So this is one of the more dramatic charts that to see, and I'm not sure people really understood this, that during the Great Recession, the recession that happened right before President Obama was elected, we saw a huge drop in jobs. And we thought that would be the worst one we'd ever see until we saw the COVID recession. But one of the things we saw is that both metro and non-metro areas about the same. But notice that metro areas came out of that eventually after about 4 years, and their employment came back, but non-metro employment never came back to where it was. And then you see what happened with COVID. We saw another big, huge drop, that recession was actually bigger than any recession since the Great Recession, since the Great Depression. And we're coming back out of it. We're not still out of it. Actually, non-metro areas doing a little bit better than metro areas, but notice we're still negative. So if you put these two pictures together, where non-metro areas are net job loss since 2008. Poverty rates in rural America have always been higher than metro areas. People are surprised to know that, remembering that metro areas include central cities and suburban areas. And so they're stubbornly so 3 to 4 percentage points higher. And that's true for almost all demographic groups: whites, African Americans, Native Americans, and so on. And you probably know this, and this relates to Megan's talk as well, and a lot of things that Sasha said. Rural America is older. I had a hard time actually coming up with some of these numbers. The median age of people living in rural areas is about 7 years older than people living in urban areas. Percentage of the population, 17% in rural areas, but 13% in urban. And remember that the age of population is going to double between 2000 and 2030 because of the baby boom generation, which I'm part of, which has huge implications for payment policy, Medicare and Medicaid. There are some parts of rural America that some hospitals have, I've seen numbers of 60, 80% of their funding comes from Medicare and Medicaid. So some people have, again, if you have that sort of Beverly Hillbillies sort of view of rural America, that you might think of the upper Midwest, Wisconsin, where I'm from, or Minnesota. You might think of rural America as being 98% Caucasian. And a lot of rural America is, and overall rural America is more white, non-Hispanic, but we tend to forget that the South and the Mississippi Delta in particular has a pretty high proportion of African Americans. And Texas has a high proportion of Latinos. So does the Southwest of Arizona, New Mexico, California. Not too many rural areas technically out there, and then there are Native American areas, reservations that have high proportions of Native Americans. So diversity is probably more diverse. Rural America is more diverse than people realize. That's important to realize. Northeast has very few rural people technically, but some of the states do. The Affordable Care Act has had profound impacts on the uninsurance rates. That's a lot of what I've studied over the years. As you can see, in general, the uninsured rate has dropped about 6.6% between 2013 and 2019. What people may not realize is it's had a bigger impact in urban areas than rural. And the uninsured rate started out higher in rural areas than urban, and it's now, the gap is wider. Probably the reason for that is, frankly, that more rural people live in states that did not implement the Medicaid expansion. 75% of rural people live in the South and the Midwest. I live in Missouri. We just passed Medicaid expansion after a big fight. And there are 12 states left that haven't passed Medicaid expansion. They're almost all in the South. So that's relevant as well. So, and so all this sort of plays out in, I think, in what you often hear about as one of the headlines, which I think is, I'm not a doctor, so I think it is more of a symptom rather than a cause, but rural hospital closures have been the highest in the last, probably 10 years than they were in the previous 15. So we've had 138 rural hospital closures in the last 10 years since 2010. And we've, there's a busy chart here, but you can see this data from the University of North Carolina's Shepherd Center. 61% of those closures are in the South. The yellow dots, by the way, show the ones that have been since 2010, and the blue dots were before that. And not all the time were they complete closures. 98 times that was the case. 83 times they were converted into something else, such as a primary care facility, long-term care facility. But there's a lot of angst and attention to the rural hospital closures for probably good reasons. I would posit in my own mind and among rural health researchers that all the things that I just told you about, depopulation, poverty, reimbursement issues, are, I think, some of the causes, but not all of them that we need to be thinking about. I will throw this out. You may or may not have seen this. The center that I'm affiliated with, the Rural Policy Research Center, I didn't do this work, but one of my colleagues did, came out with, has been tracking the COVID mortality rates. And they do this daily, scraping the data from CDC, and then do a rural urban differential on this, and do a nice job of mapping it. And one of the things you'll see is in the early part of the pandemic, as you probably know, it was primarily an urban phenomenon in New York, Chicago, Detroit, so on, San Francisco. But about August of 2020, it flipped and became, at least by COVID mortality rates, morbidity and mortality rates, it became the rates were higher in rural areas. And it was like that until early 2021, and the rates were about the same. And in the recent Delta variant phase, it's now twice as high in rural areas, as this headline got a lot of attention, and they phrased it in a pretty dramatic way. COVID is killing rural Americans at twice the rate of urbanites. So, so if all that I just previously said was not bad enough, now COVID's hit. And I will throw that on top of this, which I don't know if you picked up on this literature, but in Case and Angus Deaton is a Nobel laureate in economics who wrote, and they wrote a paper a few years ago, which has been characterized as the deaths of despair, and the map sort of illustrates it, that they picked up on a finding in the literature of basically for years we were seeing steady improvement in mortality rates almost everywhere and almost for all people. Of course, rates were higher for African Americans, Latinos, but most rates were improving for all population groups. But then we started to see them getting worse for white non-Hispanics, mostly in rural areas. And when they dug into the data, the causes were, or the cause of death were alcohol, substance abuse, guns, particularly suicides, also obesity. And that got characterized as the deaths of despair. And so there was a lot of writing about that, and trying to figure out what's going on. I would add on top of that, the previous slide, now we got COVID on top of the deaths of despair in rural areas to make matters worse. So that's all the pretext to is telehealth and the answer to rural health. As our two previous speakers talked about, we've been talking about rural telehealth for years. And I can tell you in the rural literature, there's in rural policy environment, people said telehealth, that's the answer to all our problems in rural America, because we have workforce shortages, we have all this, but it really hasn't taken off, as particularly Sachin said, until the pandemic, and then it exploded for reasons that he articulated as well as I will. And I'm going to just mirror some of what he said here with a few slides to illustrate it again. But what I'm going to show you is that I think we still have some particular differences and disparities that are struggles. And I'm going to mostly pull from a survey that was done by Kaiser. And these data are not particularly recent right now. We need new data, I think, but pulled from MEP survey, I believe. So anyways, as Sachin mentioned, before the pandemic, about 18% of people were using telehealth, described as telephone plus, video. And then that exploded to 64% during the pandemic. So huge growth. There's lots of ways to show this. This is one way to show it. Now, how did that break out by rural and urban? Again, about 2/3 of providers offered telehealth, but only 2/3 of urban providers provided it, but about half of rural did. So already you're seeing a difference. 21% of urban beneficiaries, but 30% of rural ones said they don't know if their providers offered telehealth appointments. So we're starting to see a difference. More than one, and these are data based on Medicare beneficiaries, more than 1/4 of Medicare beneficiaries had a telehealth visit between summer and fall. So that's a really large number, obviously. And there was some notable differences. And notably, some of the people, it was higher among Medicare beneficiaries. I'll note this because the data would be different if you look under age 65. But it was more likely with people with disabilities, dual eligibles, actually African Americans, Latinos, and those with chronic disease. But related to what Sachin pointed out, a majority did it with telephone only, particularly those in rural areas, 65%, as opposed to 50% urban. And the technology varied widely. Less than half of beneficiaries, and I think this relates to what Megan said, less than half of Black and Hispanic Medicare beneficiaries say they want a computer, 84% of urban, 78% of rural. So you can see we have some notable disparities and differences that we need to deal with. So I'm going to turn in my last few slides here to talk about the policy responses, the challenges we face, say some of the same things that our previous speakers have said, and will be in a lot of alignment. I'm going to pull from some articles that are in the literature and kind of try to draw some threads, and also end with some comments that our rural health panel rubric has said. Here's what a couple authors have said in literature. The references are here, and I'll send the slides to Albert Center afterwards. So you can see for telehealth to be successfully implemented, we need to focus on coverage and reimbursement. Again, you heard that earlier. Licensure, internet access, privacy and security. We need to think about technology and infrastructure, funding, reimbursement, and closing the digital divide, equity. So, a lot of consistency among the three talks I think you're hearing. The Bipartisan Policy Center, I don't know if you're aware of them, but you probably are, launched a rural health task force and developed recommendations to how to deal with the rural health systems, including telehealth, and some of the things that they said to focus in on were support broadband, expanding broadband. As Megan mentioned, that's an issue, and you could see it in the data presented. Continue to prioritize connecting rural areas, remove restrictions on that prevent currently available technology when broadband is inaccessible. I think Sasha mentioned that. Expand use of authorized sites, streamline licensure requirements, prioritize training. You know, my view of what's happened that caused the explosion during the COVID periods, we did a lot of these things. We expanded the licensure, we expanded the reimbursement, we expanded training and IT. The only question is whether that'll continue at all levels. So in getting prepared for this talk, I actually came across, I don't know if any of you have seen this, a really nice literature review. Our concluded a comprehensive literature summary, which was released just last week, I believe, October 12th. And I'd encourage you to pull it down. Drafts of systematic review. It's not finalized, I don't think. It was presented at a workshop last week. So they conducted a comprehensive literature review of 138 studies, looked at the improving rural health through provider-to-provider communication, looked at, as you can see in the red here, regional or national use, effectiveness, barriers, and the methods that were in the studies. And I'll just pull out some of the highlights from this. We can dive into it a little later if you want as well. One of the findings I'll note a couple times is the studies were limited by their less rigorous design, small sample sizes, and lack of analyses for bias. There's a nice little diagram. You won't be able to see too well on the slide unless you got a really good screen, but I thought I sometimes like these nice little charts that have you think about what way to think through the process. And it's got patients and populations and providers and payers on the left-hand side. It's got barriers and facilitators on the top, implementation strategies and adverse consequences here. And then over on the right-hand side is outcomes. So if you like those sort of diagrams, there's a diagram for you. And the questions they looked at is what's the uptake of different types of provider relationships? What's the effectiveness? What strategies work? What are the barriers? And what are the weaknesses in these studies that they looked at? What did they find? The evidence base is limited, but the studies do report better patient outcomes in some clinical scenarios. Outpatient care for depression or diabetes, I note that, where telehealth increases access to expertise and high quality care. In other applications, telehealth results in outcomes that are similar. And so one of the things I would note here is I wonder whether it picks up on some of the things that were brought up by our two previous speakers, such as the benefits to the patient in terms of saved time, in terms of transportation and travel and all that. And they mentioned the methodological weaknesses as well. So this picks up on some of the other findings as well. They found there'll be these are some of the main points that they bring up in terms of improving rural health, use provider telehealth for rural populations, and it may provide benefits for some of those things I mentioned earlier. We have to think about the barriers and facilitators such as provider time, technology, resources, as well as the lack of understanding of the rural context. That's one of the reasons I spent a lot of time thinking about the rural context. I don't think that gets enough attention. And the methodological weaknesses of some of the studies. So I'm going to finish with the findings that we sort of drew for a paper that we wrote a few months back as part of our Rupert Rural Health Panel. And we talked about preconditions for use of telehealth. We started by looking at the literature that had been written to date, which wasn't a ton at that point. We looked at the bipartisan commission's work, and we kind of summarized it into what we call key preconditions for the effective use of telehealth. And you're going to start to see some parallels with what I previously said and what some of the previous speakers have said. The preconditions we pulled out were broadband access, broadband capacity, which includes access and affordability to broadband, which is a real challenge in rural areas, as has been mentioned. But in addition, providers need to have access to the capacity to create telehealth. I think one of the things that I think surprised a lot of us was after years and years of creating or pushing a lot of money out for telehealth, and particularly for rural areas, when the pandemic hit, the explosion was in urban areas and particularly in suburban areas. And when you think about it, that was probably not a big surprise, because very well off healthcare systems that had the capacity to invest very quickly during the pandemic in the IT, in the infrastructure, and the training to do telehealth could turn on a dime and do that, as on-site services fell to the floor, like Sachin mentioned. And I saw that happen like at Washington University, where they were panicked about like elective procedures dropping to the floor, and we still needed to see patients, but a place like our medical school could turn around and invest in telehealth very quickly. And obviously it could happen at University of Chicago too. But the capacity to do that in rural areas is going to be very variable, because they don't have the capital or maybe the expertise to do it. And that's a real concern. The authority, the licensing, the scope and practice, the credentialing we brought up, mentioned by previous speakers as well, the willingness to do it. And Megan talked a lot about that, both speakers did. And do the providers have the assistance, the technical expertise to do it, and the willingness to do it? And then, I'm an economist, so frankly, I would say it's all about the money. So I wondered, about like, why did it take off during the pandemic? Well, we started paying for it. And as long as we pay for it, it's going to happen. And the moment we stop paying for it, it's not going to happen. So, I'd watch the money, follow the money. Future considerations, continued investment in funding for broadband is needed. Grant programs, we know that the federal government is looking into this among their zillions of priorities in the infrastructure bill. We need to expand delivery sites for providers and the types of providers that could bill for telehealth services. We need to understand really what happened in the pandemic. I'm not really sure we completely do yet. We need to expand the opportunities to create telehealth services, not just the places that could do it easily, like in suburban St. Louis, where I live, but in places that struggle to do it. And we need to create reasonable payment for it. And I know the insurance companies are struggling a lot with whether to pay or not. And Sasha mentioned that as well. And is it a substitute or a complement? It's a really big question. So we need extended research into the effects of COVID on telehealth. It's a grand experiment in a way. And that'll be critical to understanding the future of telehealth in not only rural areas, but everywhere in all underserved communities. And we need to understand the reasons for the rural differential and frankly, the inner city, central city differential as well. So as I pointed out, so I think I got us caught up on time, right, Albert?
You did, Tim. That was, I learned so much from that talk, perhaps just reflecting my ignorance about the real state of rural America and rural health. We do have actually a number of comments in the chat that I'll bring up. And so the first comment is from Megan Heising-Sheets. My rural parents just got high-speed internet access in November 2020, other than buying very expensive hotspots. I still don't think the quality is ideal for computer video conferencing, and our phone video calls can be patchy. We have to fix this.
So, sorry, my phone's going off. Speaking of phones. So that was a comment mostly.
I'll say comment, right? Probably reinforcing.
Yeah, so I think the quality is a really big issue. And you know, we've all experienced this probably in the COVID world. You know, I'm sitting here right now in my home because actually I broke my foot. But anyway, so but you know, when I've been doing Zoom calls, sometimes it freezes, and you know, but you know, frankly, my experience with telehealth has been quite good. But anyways, I think Megan's point's quite well taken. I see Megan revealed herself.
I know, yeah, sorry, I was hiding there for a second. I just wanted to like discuss how kind of ridiculous this situation is. There's like high-speed internet, you know, cable like within a mile of their house. So it's literally just like laying a little bit more wire. And
right.
And my family has tried to call these, you know, to call the internet supplier companies and actually has offered to pay for it to just be laid. And they won't do it. So I don't know. I think there's some comments later about leveraging other health shortages to gain some kind of national movement or policy on this, but it's certainly not something that the local community has been able to fix or to change.
You know, and I don't profess to be an expert on this, and my son is very smart. He got a master's degree in computer science, first from DePaul there in Chicago, and then in Georgia Tech. And he and I were talking about the problem of rural America. And there was a really good article in the New York Times a few months ago. If you want to look it up, you can Google it up, about where what they found out is if you just layer the broadband across a map, it looks like people like your parents, or if you said parents or grandparents, have access to broadband. They really don't. And there's some problems with GIS. They said the real problem is where the lines are located is not well mapped out. And I don't profess to understand it because it's not my area. But they said, you know, we have a really good mapping of it in urban areas, but we don't in rural. So anyways, I better stop because I don't know any more than that, but that's really part of the problem, I think.
I just wanted to ask you, Tim, it's what was shocking to me is just how we sort of, at least in academic circles, talk about the experiments in rural health or video conference calling. You know, that all the case examples come from New Mexico or from rural America, but it's not the reality. What's the political dynamic behind not having broadband in rural areas? I would have thought that would have been of interest under Republican administration, Democratic administration, that, you know, it seems like something that there could be some common interest in improving broadband access.
Well, look at how hard it's been to pass this infrastructure bill. That's one thing I'll tell you, but it's, you know, there is vast spaces, I think, in one end. And, you know, I think it's, you know, I think when, I've been in health policy for 30 years, and when people, you can get a lot behind putting money into bricks and mortar. So, we poured a lot of money into hospitals. I can tell you, when we go to the Hill, people really want to put money into, when you say hospital, they'll do that. Congress loves to put money into beds.
Physical.
Yeah, and we've joked a lot about, they don't really understand so well things like internet access and how important that is to rural providers. And I think the other thing I would say, and I know we're probably up against time, I know Scott revealed himself, but I think that there's something we can talk about later too, is there's a really huge divide, I think, between rural providers that are unaffiliated and affiliated. And I encourage you all to be thinking about that. So when I go around Missouri, for example, and the ones that are affiliated with our medical school, PJC, have so much more access to everything from, outcomes research to the training to do something like telehealth. But if you go to ones that are unaffiliated with a medical school, with a university, they just are really, they can't even get started to even get grant money. So there's grant money. What I hear is there's a lot of grant money that's thrown out by HRSA and CMS and other places, but they're not able to compete for it because they don't even really know where to get started.
Right.
So anyways, I don't know if that helps.
Well, that's a great start to the conversation. We have actually many other comments in the chat, but we'll have to save that for 12 o'clock. Mary, can you end the recording?